Everyone, we're going to get started since we've been running behind today, and we do want to get to the closing session as well. My name is Dr. Alder Tillman, and I am the County Health Officer for Montgomery County, Maryland. I've been there for about 11 years. We have a very diverse county, more than 1 million people. 1/3 of our population speaks a language other than English. And so it's a significant challenges that we have. But my job today is actually to serve as moderator. And I want to introduce our panel, and then I'll give just a few stats that we have for Montgomery County, and hopefully that will give the context, some of the context of what we're talking about. Okay, Dr. Susan Pancratz is the clinical director of the McGarrick Center Medical Clinic in Catholic Charities, and which is in Wheaton, Maryland. And she is a graduate of the University of Pennsylvania School of Medicine and is board certified in family medicine. She has worked in urban community health for over 20 years, and more than 10 of those years were focused on Latino population in the Washington, D.C. metropolitan area. Next to her, we have Dr. Ricardo Fernandez, and he has worked with underserved communities as a physician for more than 20 years. And before accepting his position as Chief Medical Officer of La Clínica del Pueblo in the fall of 2012, he worked in a variety of community and private practice settings and held a teaching position at the George Washington University Medical Center. Dr. Fernandez has served as a volunteer physician with La Clínica and other community health centers over the years, and has provided organizational leadership as a board member for La Clínica. Dr. Fernandez is committed to providing high-quality medical care to the medically underserved, and he spent the majority of his career serving the vulnerable populations and communities in Washington, D.C. area. He received both his BA in Spanish language and literature and his medical degree from the University of Wisconsin-Madison, and completed a residency in internal medicine and primary care at George Washington University Medical Center. And then our last speaker will be Dr. Basim Khan, who is the Executive Director and a primary care physician at Neighborhood Health, which is a federally qualified health center in Northern Virginia. And Dr. Khan joined Neighborhood Health in 2011 as an internal medicine physician. He became medical director in 2013 and executive director in 2015. He received his medical degree from the University of California, Los Angeles, and did residency training at the University of California, San Francisco in the primary care program that is based at San Francisco General Hospital. He also has a master's degree in public administration from Harvard University's Kennedy School of Government, where he was a Center for Public Leadership Zuckerman Fellow. And he did his bachelor's degree with honors from Brown University. And his primary interest is an increase in access to affordable, high-quality health care in Northern Virginia. So this afternoon, we are looking at innovative practices to address chronic diseases among the Latino population. And I just had a few statistics from our Healthy Montgomery, which is the community health improvement process in Montgomery County. And number one, fewer Hispanic residents report receiving important cancer screening to detect diseases like colorectal cancer, breast cancer, and prostate cancer. And even though the incidence remains low for those diseases, few actually get the screening. Hispanic females have the highest incidence of cervical cancer, even though more Hispanic women report having had routine pap smears than any other racial or ethnic group in Montgomery County. Diabetes, Hispanic adults have the second highest reported diagnoses of diabetes in Montgomery County. Obesity, Hispanic adult residents report eating fewer fruits and vegetables daily. They report having less regular exercise in their lives, and they have the second highest rate of being overweight and obese in our county. And Hispanic teens report one of the highest weekly consumptions of soda or pop, and only 25% of them report no consumption. Cardiovascular disease, Hispanic residents report, and this is the other direction, report one of the lowest rates of high blood pressure in the county. So those are just some of the background stats, and more importantly for Montgomery County, our Hispanic Latino residents report less access to health care services, and fewer report being able to have a routine checkup. And 25% of the Hispanic residents in Montgomery County have no health insurance coverage, although that's been improving since 2012 with the implementation of the Affordable Care Act. But that's still some significant concerns. So I would like to start with Dr. Pancras, who's going to be talking about improving health outcomes in the Latino population.
Well, good afternoon. We're talking about health disparities today, and certainly that is our challenge, and we just heard a little more in detail about Montgomery County. A little bit about the McCarrick Center. We started as part of the Spanish Catholic Center in 1967 in the Adams Morgan, Columbia Heights area in D.C. And the center was started to provide medical and dental services, social services, educational services to the underserved Latino population in the D.C. area. So that really is our history. Somewhere around 10 years ago, we came under the umbrella of Catholic Charities of D.C., which is the largest social services provider in D.C. But we just have 2 medical clinics in that larger organization, one still in the Adams Morgan, Columbia Heights area of D.C., and then the McCarrick Center, which is in Wheaton, Maryland, which has a very large Latino population. So when we talk about improving health care, certainly we have to know where we are. We heard some of the statistics of where we are in Montgomery County, where we want to go, and then look at processes that are going to help us get there. And for us, we just serve an uninsured population. And so resources are a challenge, as they are with all of us. And partnerships are very important in moving from point A to point B. And I want to highlight some of those that have been helpful to us. So I'm just going to look at 4 programs that we have at Catholic Charities for our Latino population: our Chronic Care Initiative, our Nutrition and Health Education Program, an interesting study that we did in collaboration with Georgetown. It's a depression and diabetes self-management intervention, and then finally our cancer prevention program. In terms of our Chronic Care Initiative, just maybe 4 or 5 years ago, we started to be a lot more intentional in giving evidence-based medical management and continuity of care for our patients with chronic disease, particularly diabetes, hypertension, cardiovascular disease. We started several years ago a diagnosis-based peer review process with updated clinical guidelines that I'll mention more in a moment. And then we started a case management program for high-risk patients that including individualized patient education, self-management goals, weekly follow-up, as well as group diabetes focus groups and nutrition education. And then we started to really look at, this data here is actually just in this bar graph to the right, but started to track some numbers to get outcomes, to see how we're doing. This is an example of some of the parameters that we're tracking: LDL, hemoglobin A1C, blood pressures in our diabetics, eye and foot exams, and then blood pressure control in our hypertensives. This is our data from 2014, and then our data from the 2015 fiscal year. And we've seen some significant improvement in some of our data. So for example, in Q4, that you can see the second to last row there, our diabetics with hemoglobin A1Cs less than 8, 59%, which is really an improvement for us. Of course, we have a long way to go in our A1Cs that are greater than 9. We still have 29% of our diabetics that we care for in that category. We've started to track just simply having diabetics on moderate and moderate intensity statin drugs. We used to look much more carefully at LDL numbers, and now we're looking at our success in getting people on statins and keeping them on statins. In terms of our eye and foot exams, we have a clinic in Northeast that we run several times a month. We have a volunteer ophthalmologists and nurses that do retinal and foot exams. We're good at referring people. Actually getting people to go and get those exams is a little more challenging. And we're having some good success with our hypertension control. So one of the things just in measuring our outcomes gives us a sense of how we're doing generally with our population. And then in our peer review process, what we've started to do as a provider staff is every other month during our monthly meeting, we'll have one of the providers update a clinical guideline. It might be in diabetes, hypertension, cervical cancer. And then the following month, we'll do a focused peer review process where each provider will review 6 to 8 charts of their peers with that diagnosis. And in addition to a general chart review, we have some specific parameters that we'll look at that are linked to that diagnosis. So if we're doing diabetes, for example, here on the left, we'll look at how we're doing with hemoglobin A1C and blood pressure, retinal and foot exams. And then each provider is able to see in specific patients how we're not meeting standard of care, and we can go ahead and refer those patients to our personnel who can do case management. Another program that we've had for a number of years is called PASOS SALUDABLES, and we originally were able to implement this program with a grant from the Allen Foundation in our DC clinic. And that program has evolved over the years, but some of the things that it has included are nutrition classes, diabetes education, together with that, grocery store visits for our patients, exercise classes. We've had a Zumba instructor that had helped us with that, and cooking demonstrations where a nutrition educator will demonstrate preparing a healthy meal, and then we also purchase the ingredients for that meal for our patients who can take them home and try it at home as well. In our Maryland clinic, we've partnered with the University of Maryland's Extended Food Nutrition Program, and they've provided us with a nutrition educator. And then going forward, we'll be partnering with the Primary Care Coalition's Sweet and Salty program, which is focused on patients with diabetes and hypertension. So I just have some visuals. Some of our patients walking to the grocery store that's close by to our clinic at the McCarrick Center. And our nutrition educator going through the aisles with them, pointing out healthy food options, options that aren't so healthy, explaining how to read labels, how to shop on a budget. And that's been a popular program with our patients. And here she is demonstrating how to prepare a healthy meal and the ingredients for a meal that patients take home with them so they can try it at home. Does it? We happen to have a gym at our facility at the McCarrick Center, so here's some of our patients demonstrating their rhythm with our Zumba instructor. Some of our providers do not have as much rhythm, I've noted. We often have participated. This is data from a pre and post session assessment on some of the educational topics that we try to instill in our patients. You know, we see good improvement in patients following intervention and eating vegetables and reading nutrition information on packages. We still have a lot of trouble with patients running out of food before the end of the month, you know, who haven't learned how to shop in a more economical way, or who just run out of money at the end of the month. So it's really a challenge for our patients. A third program I just wanted to mention is a program that we did with the psychiatric department at Georgetown University as a pilot program with a small group of patients. But the rationale for the program was this, that as we know, Latinos are disproportionately affected by diabetes with a prevalence of 12.1%, twice that of non-Latino white population. Central Americans and Mexicans are particularly high risk. And the prevalence of depression in Latinos with diabetes is very high as 30%. Latinos as a group are underdiagnosed and undertreated for depression. So this pilot was an integrated behavioral intervention to treat both diabetes and depression together. The way we approached it is we screened out patients with hemoglobin A1Cs greater than 8 and a PHQ-9 greater than 10. There was a baseline assessment using all of these measures: a depression scale, a summary of diabetes self-care activities, a self-reporting scale, a patient activation measure, which looked at patients' confidence in managing their chronic disease, and then a more specific diabetes self-efficacy scale looking at self-management of their disease. There were 6 sessions that had a main educational topic that included healthy eating and exercise, including glucose monitoring, medication use, also included stress management, included social support systems and scheduling pleasurable activities, things that would target both diabetes and depression. 2 of our staff were trained in motivational interviewing and behavioral activation, 1 in each of our clinics, the Montgomery County and the DC clinic. Okay, thanks. And then these are some of the results. We did see some significant improvement in all of these parameters, except for, I know this will be a shocker, exercise. We did not see a significant improvement. Perhaps we could do a pre and post assessment for all of us in the room and we might find the same results, I'm not sure, but that's something that we've seen as a challenge. That's right. And then finally, our Celebremos La Vida program. This is a cancer prevention program, initially with funding through the Prevent Cancer Foundation, through which our clinics have been able to provide screening mammograms and pap smears for our patients. And then with additional funding through the Primary Care Coalition's 3 screening grant, we've been able to improve our colorectal cancer screening as well. We provide follow-up testing for abnormal results for our patients, as well as health education. Our mammogram program has been particularly successful. We schedule 8 to 10 sessions a year with the Mamma Van coming to our facilities. We schedule 25 patients for each of those sessions. It's a time really our patients look forward to. We provide a healthy breakfast, a healthy lunch, and we have a charla where we chat with the patients about cancer prevention. They'll see videos on cancer prevention and then discuss how cancer has affected their families, and we talk about treatment. They can invite friends and family as well. This is some data from last year, and it's hard to see the final number, but there were 191 individual patients that were affected by this program, both for breast health and pap smears. This is some of our data from last year, 2014, in terms of our goals and how we were able to reach our goals in cervical cancer screening, breast cancer screening, colorectal cancer screening. And then this is from the 2015 fiscal year. You can see in for our mammogram screening patients 40 to 69, we've had rates between 60 and 72% of our patients who've received, who have had mammograms. Cervical cancer screening in our 4th quarter was up to 60% of patients who've had a pap smear in the last 3 years. And then we've seen a really nice increase in our patients who are getting colorectal cancer screening. Our providers are very good at giving patients their FIT cards, and so we have a high rate in this last quarter, 94% of patients who are due getting cards, but 62% bringing them back and getting tested. But that's a very large increase from what we were doing previously. So this is a program that's been successful for us. So that's thank you. Okay, I have to pass off my wiring here to you.
And now we'll hear from Dr. Hernandez.
Good afternoon. Thank you for inviting me. I'm Ricardo Fernandez. I'm the Chief Medical Officer at La Clínica del Pueblo. I enjoyed hearing Dr. Pankratz's presentation and Dr. Tillman's comments about the health of Latinos in the DC area. I'm going to talk a little bit about some of our health promotion activities at La Clínica. And there's, I think, quite a bit of overlap with what's happening at the Catholic Charities. Our focus, at least for this presentation, is on prevention of a chronic disease, namely diabetes, by focusing on weight loss in people that are at risk. So I'm just going to tell you a little bit about La Clínica and our patients, a little bit about obesity and Latino health in the U.S., and our diabetes prevention program, and a pilot we're conducting on group medical visits that is also focused on weight loss and diabetes prevention. So, this is the front door of our health center. It's on 15th Street in the Columbia Heights neighborhood. We're a federally qualified health center. We serve a mainly Latino and immigrant population that draws from the surrounding neighborhoods, Northwest DC, but also quite a few from Prince George's County. And this comes from our mission statement. Our goal is to build a healthy Latino community through culturally appropriate health services, focusing on those most in need. So a little bit about our patients. 91% are Latino. 80% are actually from Central America, which, as we heard, has a high rate of diabetes in adults. 42% do not qualify for health insurance. These are data from 2012, by the way. Some of these numbers have changed a little bit. 80% are more comfortable in language other than English, and 50% have an income below the federal poverty line. Most of our patients are from DC, but a good percentage come from Maryland, a smaller percentage from Northern Virginia. So we are a primary care health center, but we do have a lot of other activities, and our primary care is delivered in a team-based model. We're a patient-centered medical home, level 2. So we do care coordination. We work in teams. We coordinate with social services and health education. We have mental health and substance abuse services, interpreter services, and community outreach. So a little bit about obesity and Latino health in the U.S. This is just national data, not specific to Latinos, and it's not strictly chronological. 1990 is over here data, so where it's light blue and blue is less prevalence of obesity, and then as it becomes darker blue and tan in 2000, and then brown, that's the highest rate of obesity. So as you see over time, nationwide, there's been quite an increase in the prevalence of people with BMI over 30, particularly in the South and Midwest. One interesting thing to note is about Latino health in the U.S. is that foreign-born and U.S.-born Latinos have somewhat different health profiles. I guess, in short, the foreign-born Latinos are a little bit healthier, and I guess as they acculturate more and maybe pick up bad habits here, maybe have easier access to low-cost, high-calorie foods, soda, things like that. Some of their health statistics worsen. Obesity is an example. So this is an issue for immigrants who have children who grow up here. The obesity rate is obviously increasing. As has been noted, Latinos have less access to preventive care. In general, they're about 1 in 6 of the U.S. population is Hispanic. As has been pointed out, there's a lower death rate overall, lower rate of cardiovascular disease, but a higher rate of death from diabetes or liver disease among Latinos compared to non-Latino whites. And this is just illustrating percentage of diabetes in adults age-adjusted by ethnic group. So American Indians or Native Americans have the highest rate. Non-Hispanic blacks and Hispanics are very similar. Asian Americans lower, and whites are the lowest. This is just another slide about rates of different health causes of death, I should say, in Hispanics and non-Hispanic whites. So diabetes-related death is more common in Hispanics than it is in whites. Did you want to see that? Okay. Okay. And another interesting thing to note is that while there is a lot of increasingly high-quality data about Latino health in the U.S., when it comes to undocumented immigrants, there's less because the surveys don't really distinguish between documented and undocumented immigrants, and there's obviously quite a bit of difference in their experience and what happens to them when they come here, psychologically and physically speaking. So there's about 11.7 million undocumented in the U.S., and as I said, there's not a lot of data about the health outcomes of this subset because there's no data collection on the legal migration status. And there's quite a possibility that different factors affect their health in different ways. Migration and et cetera leads to different experience as they come to the U.S. versus legal immigrants. So seeing as how the rate of diabetes is high, and we know that's a cause of morbidity and mortality in Latinos that's important to address, we want to see if there's a way maybe to prevent diabetes in the first place through focusing on healthy lifestyles and weight loss. So at La Clinica, the health education department has been conducting groups called the Diabetes Prevention Program groups in the past 2 years. And I'm going to tell you a little bit about that. The methodology that's been used is an evidence-based toolkit that comes from the CDC called Road to Health. And we used community health workers and health promoters in addition to staff health educators. Some of the health promoters and community health workers are volunteers to work with patients at risk for diabetes on their health behaviors. In particular, topics like reading food labels, making healthy food choices, portion size is a big point of emphasis, and physical activity. So we've had 2 cycles. The first cycle was in the fall of 2014, and there were 3 groups. And they met at times that were convenient to patients. This is just some of the summary of what happened with the groups. All 3 groups were completed. It consisted of 6 weekly sessions with the health promotion staff and sort of dynamic interactive exercises with the participants. 31 individuals participated. They assessed larger numbers to see who might be able to be eligible and invited people, and they ended up with that number. And it was a little more female than male in composition. So actually, there was a success in terms of the weight loss in these groups. The average weight loss was about 7 pounds. And participants reported that they were decreasing their intake of sugary drinks, increasing water consumption. Okay. Decreasing fast food intake. They had less success in reading food labels and reducing fat and calorie consumption. Part of the activity was training health promoters to conduct these groups. There was a second cycle, which was only one group, and it had a similar. I'll skip to the end. There was average weight loss of 8.9 pounds in that group. So some of the lessons learned were that when the patients were more likely to participate if their provider had actually invited them or suggested that they go. Incentives such as food cards, T-shirts, pedometers, things like that were helpful in retaining participants. They should weigh the patients on the same scale. I guess they found that to be important. Most of the participants were able to lose weight and report more physical activity. So I just want to mention that we're also, based on this experience, we're conducting a pilot on group medical visits focused on weight loss, using pretty much the same curriculum but involving a primary care physician in the group and doing it as a group medical visit. So it had similar goals, but the involvement of the physician was to give it a little bit more of a medical orientation. One of our docs is particularly interested in weight loss and obesity treatment and prevention of diabetes. So there was a team that included, in addition to health promotion staff, the primary care doctor and a nurse manager and medical assistant. People that were targeted were obese and overweight, known prediabetes or elevated fasting glucose, metabolic syndrome, history of gestational diabetes. And one of the ideas was to target women of childbearing age with the idea that they can pass on some of this knowledge and healthy behavior to their children. And also, if we know that if a woman is overweight and has a child, her baby is more likely to be overweight and potentially at risk for diabetes in the longer term. So looking at this sort of public health goal of preventing obesity in the community. So in this group, there were, in this pilot, there were actually only 4 patients that participated in this weekly weekly sessions for 6 weeks, and then they had two follow-up sessions at 4 weeks and 8 weeks afterward to check in with patients on how they're meeting their goals, and also for the provider or labs if that was appropriate. And there was a portion of the group session where the provider met one-on-one with the patients. And this is just an example of how the weight was tracked in a couple of the participants, and there was a modest weight loss by the end. And in the group medical visits, some of the barriers and issues that were identified were, these were conducted during clinic hours, so it was a little challenging for some of the patients to make all the sessions. There were some challenges related to the billing. The provider had to bill based on the time that he spent counseling and one-on-one with the patients. Also, some of the patients objected to having to pay their copay or their sliding fee for 6 weeks in a row every week. It is a challenge for some of our patients. Some of the other lessons learned were that patients needed a little more time to learn some of the nutrition concepts, so that the staff had to be a little bit adaptable, spend more time in one session on nutrition, on label reading, for example, to meet the patient's needs. Again, the material incentives were helpful. And at the end, what they found was a very helpful exercise was sharing a meal with the participants, the provider and the staff and the participants shared a meal, and they would continue the discussion and reinforce some of the points during that meal. And some of the participants would actually use the recipe and come back and say that their family liked it, and so that was pretty gratifying. Okay. So thank you.
And we'll now hear from Dr. Khan, and then we'll have time for questions.
Okay. Thanks for inviting me. we are also a federally qualified health center at Neighborhood Health across in Virginia. So I'll start off by telling you a little bit about our health center and then go into some of the programs that we're involved with as well. And FQHC, 9 different sites in Alexandria, Arlington, and Fairfax County. Our history is we began about 15 years ago in the basement of a small apartment complex in a very predominantly Hispanic part of town. It's called Arlandria, actually. If you think of Arlington and Alexandria and put it together, that's what it is. And it was initially started about 15 to 20 years ago with services for mothers, pediatric services, and slowly grew from that little site. I joined about 4 years ago and got to see that basement setting only once. Apparently they had to shut it down because of fire code violations, which I wasn't surprised about. But space was an issue then, and it continues to be an issue, but we've grown significantly in the meanwhile. Currently we have about 15,000 patients. We provide primary care, dental service, behavioral health services. In Virginia, one interesting thing is that most of our patients are uninsured. About 2/3 don't have any form of health insurance because qualifying for Medicaid in Virginia is completely different. So if you're an adult, you really have to have a disability. If you're an adult without children, you pretty much don't qualify for Medicaid. If you have children, unless you make, I would say, less than $6,000 per year for a family of 3, or have a disability, you wouldn't qualify for Medicaid either. So a very different landscape. Large immigrant population, about 60% are Hispanic, but in our sites, original sites, it gets closer to 70-80%, mostly from El Salvador, Bolivia probably being the second largest, and then a little, a few patients from Peru and other Central American countries. Then a large African population from Ethiopia, from Ghana, a large South Asian population. So very immigrant heavy. And I'm trying to see if I have a map. I'll go back to the other slide after I show you that. So right across the river, we're at the top right in DC. And the dark blue are our primary medical sites. And the one over here, this one, is where we initially started off, and we continue to have a site that offers primary care and behavioral health services. So the blue ones are the other ones that are medical and behavioral health. The second one to the left is on the campus of a hospital, Nova Alexandria Hospital, which is convenient for a lot of different reasons. And then the one at the bottom, the blue one at the bottom, is now our main site. It's the building over here that we've recently acquired and have expanded a fair amount into Fairfax County. The 2 green sites are dental-only sites. We have very strong partnerships with the local health departments and offer dental services within their spaces. And then the red ones are community services board sites. And I'm not going to go into that right now, but now that I think about it, I probably should have, because it's a very useful program for patients. It's within the community mental health sites where they get outpatient behavioral health services, counseling, psychiatric care, case management. These are patients who are seriously mentally ill, schizophrenia, psychotic disorders, and we send a primary care 2 days a week to each of these sites and have somewhat of an integrated, definitely a co-located model. As you can imagine, for the patients, it makes a lot of sense because they get their behavioral health, mental health services in one location, and then they probably get primary care in the same location as well. 2 different organizations providing the services, so there's a long way to go in terms of integrating care, but it's been a successful program. In fact, we started off with Arlington and Alexandria. The Arlington one sort of right on the green as well in the same location, and more recently opened the one down in Fairfax County. In terms of the services we offer, pretty standard for health centers, for those of you familiar with the services we offer. Primary care, that's primarily what we offer. Mostly adult patients, so I would say 10,000 patients are adults, 5,000 are pediatrics. Very different patient populations in terms of access to health insurance. So our adults are mostly uninsured and our pediatric patients are mostly on Medicaid. That affects access to services that they're able to obtain, which I'll get into a little bit. Basic women's health as well. We have primary care offering GYN services, and then we have one gynecologist on staff who does a little bit more on-site lab services. Again, this is fairly standard. able to order pretty much any labs that a patient needs. We have pharmacy assistance program services, so if a patient needs medication for diabetes, hypertension, and they're uninsured, they're able to get it through local pharmacies for a discounted program. But for those medicines, primarily insulin, inhalers, there are a few medicines that you cannot get for a low price in the pharmacies. We have different programs to help them with that as well. Some case management, some sort of referral coordination. We refer radiology to the local hospitals, and that gets slid into their charity program. So we tend to, we're able to get radiology services for our patients. I'm primarily talking about uninsured patients who would otherwise have barriers. Specialty care is a very big challenge, and I think that's a difference between us and a lot of other health centers, even within the area. For pretty much any specialty care referral, we have to send them down to UVA. And that's just something that I want you to process. From Arlington, we're telling them to go to Charlottesville for what can be a 15 or 20-minute appointment for people who might not have access to a car, for people who get paid by the hour and thus have to take off a day from work, and for people who need a colonoscopy. So think about the prep. I mean, it's just surgery. And this is the standard. So every specialty care, I see patients as well, every specialty care referral we do, UVA is the first option. Not Georgetown, not GW, not Inova, which doesn't have outpatient specialty care. And that's, given that our adults are 80 to 90% uninsured, that's pretty much all our patients. There are a few things we can work out. There's a Project Access in Northern Virginia, which has access to some specialty care, but it's far and in between. It's very limited. So that, as you can imagine, affects a lot of our chronic care. We tend to have to take care of more in-house, which I'm sure is similar to what you do as well. But cardiology needing a stress test, we just send to the emergency room. So that's something that we have to work around as well. Our partners are very committed to try to change this, but in the healthcare marketplace that is Northern Virginia, it's challenging. So I'm going to talk about 3 different items. Hopefully I'll have time. I invite more questions if you have questions about them in one more detail, because I'm going to go fairly fast given the time we have. And one is our open access scheduling model, which I think would be of interest to some people. And then the other is behavioral health integration within our primary care services at our main sites. And the other is a high utilizer program. So our open access scheduling model was implemented about 1 to 2 years ago. It was in response to a very high no-show rate, which I think a lot of us struggle with. And basically, we used to have a traditional model where if you needed an appointment, you could schedule it 3 months in advance, get the appointment. Usually, if a patient is seeing me with diabetes, I tell them come back in 3 months. They schedule the appointment. They have a card that says you need to come back in 3 months, and they walk out the door with the appointment. The challenge with that was, as you can imagine, a challenge we all face is the slots get filled up about 3 months in advance. And then if someone called in for an urgent appointment, they'd have to be squeezed in, or we'd have to come up with some way of fitting them in. It's a challenge in most safety net primary care settings that I've found. We also had a challenge with no-shows, because if 30 to 40% of them wouldn't show up, you would lose access that way. So at the time, a decision was made to move towards an open access model. The reason I'm talking about it is because we did it exclusively across the board. And that is something that I think isn't too commonly done in other health center settings. So our patients are not allowed to schedule an appointment more than 1 week in advance. So that means if I have a diabetic patient that I want to follow up in 3 months, they have to actually call back and ask for an appointment a week in advance, and then they're able to get it. And the way we do that is we don't even open up the templates. So it's actually not even possible to give them the appointment. In the past, when we used to try to implement such models, the rules would, quote unquote, be broken. So, and the other people in similar settings probably understand what I'm talking about. So we would tell our schedulers, don't give them the appointment if it's more than 1 week out, but invariably they would do that because you have patients really wanting the appointments on the other end. So we changed it to a system where we don't even open the template, so it's not possible to do that. Obviously decreased our no-show rate to 10 to 20%. More access for urgent cases. So if you're not able to, if you call in, you're not able to get an appointment, you can actually call back the next day and a whole new schedule of appointments open up. And it actually gave more flexibility around schedule changes, vacation requests. If someone wanted to take time off and it was 2 weeks in advance, we were able to actually accommodate that request because, oh wow. So I can get into more details about that, but an example is if someone called in and they wanted an appointment for October 14th, they would have a whole list of appointments to choose from. But if they wanted something from October 15th, nothing's available. The next day, October 15th opens up. There are challenges, though, because it's a trade-off. And the trade-off is, are we decreasing access for our chronic disease patients who might fall through the cracks, who forget to call for an appointment, who call but can't get it and then give up? So whenever it comes to supply and demand of access, the question is, what type of patient are you trying to cater to? People who need urgent visits or people who need chronic visits? So for our well child 3-month visits, we actually ended up changing it back. We're trying to decide whether for our chronic disease patients, whether to change it back or not. It's really nice in cases when we need to titrate stuff. So we adjust someone's insulin, we tell them come back in 3 or 4 days, we actually have an appointment available in 3 or 4 days. So our providers prefer it this way, but it's always an ongoing debate. How am I going to fit the other two things in within the next 4 minutes? Primary care behavioral health. We used to have a very traditional model, separate sites, separate departments, 1-hour therapy sessions, high percentage of patients that utilize behavioral health and primary care with different patients. Over the last year, we've tried to integrate it some more. We're now doing universal screening for depression, brief interventions by the primary care team. Once a patient screens positive, the medical assistants, providers, nurses are all involved in this. Changing the templates so it's more short counseling visits in the behavioral health provider templates. We're doing team huddles as well between behavioral health and primary care at the beginning of the day so they can actually talk about the cases and say who might need more attention. And the idea is to, as you can imagine, integrate services. Advantages, our screening rates have increased significantly, many more referrals. I would say the challenges, and I'd invite other people to share their experiences, that we still have resistance to behavioral health services to some degree. So I screen a patient for depression, they screen positive, and then they still don't want to see the counselor. And the challenge is then they end up sort of going into a counseling-ish type session with the primary care provider, and that's where the primary care providers are pushing back a little bit, saying that, here you've sort of increased that workload on us, and the patient's not willing to go to the counselor because there's usually a cost associated with that. We've made the first visit free, but then the subsequent visits, they don't want to go. And then some of it is stigma as well. I am definitely encountering that. So we've had training around how to actually approach behavioral health. Can you approach it more from a chronic disease management point of view, that we see that this is impacting your ability to control your diabetes or eat healthier or do X, Y, or Z? Can we have you talk to a behavioral health counselor to strategize around working around that, or as a team? And we've had some movement in that direction, but not as much as we would like. The last thing I'll quickly talk about, and I welcome questions, is we've started a high utilizer program. There are programs like this around the country. The Camden Coalition with Dr. Jeff Brenner is sort of the one that's been highlighted the most, identifying 40 to 50 high utilizer patients, 3 hospitalizations or 2 ED visits in the last 6 months, giving them intensive case management support with hooking them up with social services, medication, reconciliation, behavioral health support, home visits. The goal is to increase the ability to navigate the healthcare system, improve chronic disease self-management. It recently started, so don't have too many results right now. I'll say, though, that our access to specialty care will affect this to some degree because, so I think we're different in that sense, because we might be able to hook them up with a whole bunch of social services, but if you can't hook them up with health insurance, you'll run into some barriers. Having said that, it's the system that we've been operating in for the last 15 to 20 years, so that doesn't mean that there are things we cannot do. I'm sure there's a lot we can do to keep them out of the hospitals and make sure that they don't unnecessarily use the emergency room or the hospital as well. So there's a long way to go with that project, but it's something that we're excited about. I'll stop there. If you have questions, I'd be happy to talk about this in more detail. Thank you.
Okay, we will now open it up for questions. And one question that I have actually is to say for each one of our presenters, since the emphasis was on innovative approaches to chronic disease management, what do you feel is the most innovative intervention that you've introduced?
Well, that's a difficult question in that we see a lot of overlap in the different primary care centers in terms of what we're trying to do with increased case management, increased access of services. I would say coordination of care and figure out ways to target concomitant disease. For example, diabetes and depression is an area where we can really improve, and we have seen, for example, this study I'd mentioned, some innovative approaches to doing that. So that's one thing I would mention.
Yeah, I would echo what Susan said about, I guess innovative is sort of relative. Have we done something that no one else has done? No, but I think one thing I would say is that one approach that maybe is interesting is the use of community of lay people that are trained as health promoters to work with our patients, because our patients are very polite, and a provider can sit with them and say, you have to do this, this, and this, and they'll nod their head and leave and not do it. And some of it might be just a different way of thinking, a different cultural perspective. And so people that are from the community, I think, have a good feel for what motivates patients, and so that would be one thing. And then maybe group medical visits has been done before, but we do want to see how we can maybe integrate the community health approach with the medical team a little bit more than we have done in the past. It's been strictly separate, and how to work together a little more.
It's a difficult question, but how many people here are interested in primary care, work in primary care environments in any way or form? I mean, can I just have a show of hands? How many people have heard of Tom Bodenheimer? Okay. He's one person I'd recommend following or looking up his work, because there's been a lot of work done in innovation in primary care and the future of primary care. And I think it's important to really look at that, because this is something that's very important. Healthcare systems that deliver high-value, low-cost care are healthcare systems that invest a lot in primary care and that have primary care work at a high level where you can prevent unnecessary utilization of specialty care. You can have more coordination. And through the healthcare industry, there seems to be a realization of that. The Affordable Care Act has a I'm sorry, I'm going a little off topic, but I'll answer the question. The Affordable Care Act has that built in terms of the CMMI, the Innovation Center. There are demonstration projects all across the country with Medicare, Medicaid, for example. And the challenge and I think people understand what needs to be done. One talk that I've been very fascinated about, and I think makes a lot of sense, is how will primary care in the future look, or how will it look so that it meets the needs of the patients who need primary care in the future. And one problem is the mismatch between demand and supply. So we will need to have a system where you're catering to a whole lot of patients, but you only have a limited amount of primary care physicians. How do you deal with that? You increase the supply through nurse practitioners, physician assistants, and other means as well, but that doesn't do the trick if you just look at the numbers. So that's where that's where team-based care comes in. Are there ways so that a physician or a nurse practitioner can take care of more patients, but you have more members of a team that are actually helping take care of those patients? So instead of me having a panel of 1,500 or 2,000, it would be more patients, but I'm actually not as closely linked with each one of them. They're actual team members looking at this. The other piece of it is population management. Every time a physician walks into the office, the way your day is structured, you're taking care of patients every 15 or 20 minutes. And we walk into our current day saying, how can I best take care of the patients that I'm scheduled to see today? So I might have 20 patients on my schedule. Every minute of my day is actually spent taking care of those 20 patients. The reality is I have another 1,500 patients who I'm not really focusing on. And is that the best way to structure your day? Should the day be structured different, where you might have a meeting where you go over with a nurse or someone else, talk about, well, these are our highest risk patients. Can you reach out to them? Can they receive some counseling? Can these people receive some group visits? Can you make phone calls to these people? You actually see a few patients, and then maybe you have group visits with a few other patients. But it's a very different model of care than what we're used to today. One of the challenges is within our current payment system, we don't really know how to actually do that. All of us are paid to see more patients in a given day. So every program we've just talked about, actually, we need to find funding, or for most of the programs, we need to find funding to actually do it. Otherwise, they're not sustainable. When the grant runs out, the program goes away. And so the question then becomes is, within the systems that we operate, what can we do to innovate so that we stay ahead of the curve, so that when payment reform does come around, we're able to respond to that. And that's where some of these projects come in. Our hope is that when we reduce hospitalizations in the hospitals, someone's going to come around and say, you know what, we're going to share some of those savings with you, so then we can hire a nurse who can do this kind of work. Or when we reduce A1Cs or something else, maybe the health insurance companies will come around. So, we're trying to innovate in different ways, but there are just a lot of pieces to it that we're trying to work around.
Okay. Yes, here.
I have a question about your chronic disease self-management curriculum. And so I understood from you, Dr. Susan, that you're using the CDC toolkit for chronic disease self-management, or do you have a chronic disease self-management program?
Well, yes, we do. So, yeah, there's two stages of it. First, there's the primary care physician who's seeing the patient, and the physician will be looking at helping the patient to develop self-management goals that are achievable and measurable. And so the primary care physician is working on that. In addition, we have a prevention and chronic care coordinator in each of our sites, one of whom is here in the back, Olga Pulgar Vidal. She's one of our chronic care coordinators at our DC site. There's also an opportunity for individualized case management, where patients can work on self-management goals, group diabetes visits as well. And some of those programs have altered as we've had funding for different programs along the way. But in general, that is our goal, to have both primary care physician working on those as well as case management. And often in our diabetes and nutrition programs, we also have patients working on self-management goals as well.
Other questions?
Thank you. What prompted the change in your model of service? For instance, the schedule change. What kind of process did you go through in realizing, we need to do something different?
I think it was our really high no-show rate that ended up doing that. And we were afraid that because of that, access was very low, or it was relatively low. The other piece of it was patient satisfaction in not being able to get appointments for 3 or 4 months out. And it was interesting. It was 3 months, then it became 3 months and 2 weeks, then it became 4 months. And we tried working around the side by putting in walk-in visits, but it just wasn't, it created a lot of problems. A piece that I'll mention, though, is that different systems of scheduling work insofar as your demand and supply is, there's some parity. So if you're in a situation where you don't have enough providers for the amount of patients you have, whichever system of scheduling you have, it's not enough. And so every time we have a little bit of turnover, we still run into problems. But the question is, which patients are you running into problems with? So if someone has an emergency and needs to get in the next day, we're still pretty good about accommodating them. But on the other hand, that elderly patient who just wants their appointment 3 months out, wants to put it on their calendar, maybe we're not as good as accommodating them. And that's where I think an ideal system is a mix. A challenge that we've had is that in our electronic medical record, it's been a little difficult to try to work out a mix. We're doing that in pediatrics, where our well child visits you're allowed to schedule out in advance, because we're very much afraid of people not getting vaccinated. We've tended to have really good vaccination rates, and we need to hold on to that. With chronic diseases, we're thinking about maybe a hybrid model. Would that work better? The challenge is, until we feel we're at a level where our supply and demand match up, we sort of don't want to make any big changes at that point in time. But for people who are sort of grappling with this at a more micro level, we'd be happy to talk to you about it, as we've done with other health centers that have called us.
Okay. Other questions?
Was that tried?
We've had reminder phone calls. That didn't help as much, because sometimes getting a hold of patients has been difficult. I think one piece to add, though, is we have a call center. So it requires some investment in your phone answering operations. So we have a dedicated call center with a certain amount of staff that are open for longer hours than the clinic. And that's what's made this a little easier. But even then, it sometimes is difficult to catch up. Yeah, I would say 10. Yeah, I would say closer to 10%. And yeah, in the health center world, that is pretty low. Yeah.
Okay. Another question?
Yeah, so just a follow-up question. Have you all, and I know this is largely dependent upon the geographic area that you guys operate within, but have you tried using the community health workers themselves as messengers or vehicles to get people to come back to the clinic for their follow-up appointments? And how feasible is that?
For us, it's something that we're very much interested in, and I'm trying to think. It's going to be part of our high utilizer program to some degree. It's part of our Ryan White HIV program as well. Then a question becomes that of funding, just to be able to have funding to reach out to people. Another question becomes is, for our patients who need it the most, what are the layers you can put in to be able to access them? So things that we've thought about is having a registry of our patients with A1Cs above a certain level, and then we have extra outreach to them to make sure they don't fall through the cracks. So there are different mechanisms we have in place. Community health workers is one we've used in certain contexts, but we would like to be able to use in more contexts if we would be able to get the funding. Some of it also has to do with payment for services. Of course, with a high percentage of patients who are uninsured, that becomes more of an issue as opposed to people on Medicaid who don't necessarily have a large a copay. Because even we have a $13 fee, but for some people that can even be too much as well.
Okay, we have time for one more question. Being recorded.
Thank you. I also work at a federally qualified health center, and I work in a lot of these programs doing kind of centering diabetes education and one-on-one education, and I think they're wonderful and amazing. But my question is to you guys, while these programs are amazing and all this work that you're doing, when like Virginia decides not to expand coverage and, you know, patients have to go to UVA if they just want to see a specialist. I'm curious what your recommendations to us is on like kind of our political need to get involved, because if these things don't change and people are still going to have to see 30 patients a day to make the numbers work, that inherently is unhealthy for preventative health. So I want to know what you guys, when we all walk out of here today, how can we kind of engage on that political level to start making those kind of level changes so that, federally qualified health centers aren't always fighting for these grants to do preventative care. I'm curious what your recommendations are. Thank you.
That's obviously the tough question. Part of La Clinica's tradition, I guess, is a lot of advocacy work on behalf of immigrants and Latino immigrants, and so that's definitely something we're continuing to be involved in. But obviously, we run up against local, county, and state governments that they have their own agendas, and it doesn't always intersect with ours. In healthcare in general, there's going to be a need for a lot more consolidation and banding together. And I think, a small organization like ours is not going to necessarily survive, so we're going to need to partner with agencies like the ones these folks belong to increasingly in order to forward our agenda. I don't know if you have any comments.
I would just, in agreement with Dr. Fernandez, partnerships are so key. I mean, I think there will always be, with healthcare costs the way they are, our immigrant population the way it is, greater need than our ability to meet the need. Although, we've tried to make strides, certainly as a society, in meeting the needs of the uninsured. We're always going to face that challenge. I think partnerships are so helpful. I know in Montgomery County we've had the benefit of the Primary Care Coalition, which is a consortium of 12 healthcare centers, where
plus
we can, plus the hospitals, so we can benefit from one another's efforts. We can pull resources often. That's been a real benefit to our patients in Montgomery County. So I think those are the things that I feel like it's been really important to put energy into, is developing partnerships so that we're not little silos and independent organizations trying to meet needs that are just overwhelming for all of us really to meet. On the political front, I'm going to let Dr. Khan answer that question.
You imagine that. I would really second the idea of partnerships. In a safety net setting, it's so important for us to be aware of limited resources and not to duplicate things, because people have this sense of turf, or the sense of, sometimes it's okay to let go and not do something because someone else is doing it. And what's really important is for different entities to work together. We have to work very closely with our health departments, and we have incredibly strong relationships with them. As you could see, sharing the facilities, we use some of their nurses are used in our programs for some higher-risk case management because we can't afford that kind of staffing. But what we can do is provide the primary care. So partnerships are incredibly important, and it's very important to make sure that one has a sense of what's being done, sort of before one engages in advocacy to some degree, because it's really important for different players to work together. The second piece is a little bit of perspective. As much as we think that our situation right now is challenging, there are pieces that do work, and one is the health center program as it stands. It serves 25 million people. I think that's the number, and that does get federal funding, and so it's very important for that to be able to continue, because it plays a very important role, especially as more and more people get insured. There might be this tendency for people to assume that, well, there are not that many people who are uninsured, thus funding might not be needed, but that's certainly not the case, especially in Virginia, but elsewhere as well. And then the issue about Medicaid expansion is completely true. I mean, it's incredibly important. It's become very highly politicized, and it's something that people across the spectrum agree is a good thing. But yet it's so politicized that it hasn't gone forward. I'm optimistic that at some point it will, and when it does, it would make a significant difference for us, both as an organization, but also for our patients in terms of being able to refer people, and just investing in primary care in general. I mean, I can't emphasize how much the importance of primary care for a high-value, low-cost healthcare system, and the way that we invest in health, within health, in terms of primary versus specialty care within healthcare, and then within health in general of public health versus healthcare. I think our country has it all wrong in that point of view, right? We need to invest more in public health. We need to invest more in primary care within healthcare, and just continuing to advocate for that is important on so many levels, which I'm sure the audience knows.
Okay, we are out of time, but I do want to thank the speakers. I want to thank all of you in the audience for participating and attending.